Okay, so thank you everybody. Welcome. Thank you ever so much for joining us today. We've had a lot more than 100 people register, so that's really exciting. My name is Polly Livermore. I'm the Deputy Chair for the Communication Strand for CARIN, and I'm chairing the webinar today. Before we begin, just to reintroduce CARIN and some key individuals. For those of you who don't know, CARIN stands for the Clinical Academic Roles Implementation Network and very kindly supported by the Council of Deans and is free to join for individuals. Our chair of CARIN is Professor Jane Code, who's speaking to us today, and we're supported by Emma Shonbell, who's our wonderful policy officer for the Council of Deans. We're all volunteers, as actually the Council of Deans is a charity. So just in one more minute, while we're waiting for everyone to join, CARIN has some amazing work packages and some key individuals that we thought would be important just to announce to you. So the overarching communications strategy is led by myself and Professor Annette Hand, and that includes delivery of the webinars, newsletter, and supporting the website delivery. And other work packages include our careers framework, deputy chairs for that, Michelle Briggs and Fiona Maxton. Our devolved countries work with deputy chairs Ben Fitzpatrick, Juliet MacArthur, Jane Code, and Emma in discussions with Wales, with Monica Bousset, to find a temporary link. We've got an EDI with our joint deputy chairs of our Hortensia and Geeta Ramdari. Influencing policies, deputy chairs Bridie Kent and Jane Code, and metrics and input are our deputy chairs Mary Wells. So moving on really excitingly, I'm going to introduce Professor Jane Code to come and talk to us about the Follett Principles. If people can put questions in the chat, and then we will get to them at the end of the webinar. Thanks, Jane.
Thank you, Polly. Emma, do you mind uploading my presentation? And while that happens, I'll just say I'm Professor Jane Code. I'm a Professor of Children and Family Nursing, and I'm also a Director of Research, Co-Director of Research at University Hospitals Coventry and Warwickshire. And I'm very proud to be the Chair of CARIN. And I was also a member of the 2024 Follett Principles Working Group, which is where this work comes from. But actually, it came from CARIN, and I will show you in the PowerPoint how that was. And just a nod here to Professor Anne-Marie Keenan, who is herself a Professor of Applied Health Research, and she chaired the actual working group. And you can see we worked very hard together with University Colleges Employers Association, known as UCEA, NHS Employers, NHS England with Alison Richardson, and Clinical Academic Roles Implementation Network, where I was myself and Bridie Kent, and the Council of Deans of Health supported that from the outset, as did and the National Institute of Healthcare Research. Next slide, thanks, Emma. So I'm just very quickly going to tell you the update of Follett Principles and the need for the update, actually, and share what the working group did and our activities and the implications. That's the important bit for CARIN in the Council of Deans of Health. Next slide, thanks. So the background really is that really starting a definition of clinical academics are health and care professionals who work in a HEI, a higher institution, education institution, in a teaching and or research role, as well as in the NHS and vice versa, in a role that requires them to hold a practice qualification and maintain professional registration. And they're jointly employed by HEIs and the partner trusts. And so they have substantive contract, usually in one, and hold an honorary in another. Now we've taken that definition, and that definition is in the updated Follett Principles from a number of sources, and that was developed for Follett, but you will find that on a number of websites. Like there's a website called Catch, where there's some case studies, and the NIHR are using that definition. So we're starting to get to a definition, a point that we're all kind of agreeing, really. And that was our background starting point. Next slide. But what are the Follett Principles? It's quite important to sort of set the scene really on them. They actually came out of a report in 2001, which was the Redfern report, following serious concerns about organ retention in Alder Hey in 1999. So the Redfern report found that there were serious accountability and management issues of medical clinical academic staff working between the Alder Hey and also the university. Out of that, therefore, then there was a development group led by Sir Brian Follett, who actually wrote some principles which became the Follett Principles for research and responsibilities. And they really targeted that at that point about joint working to integrate separate responsibilities. Follett prescribes clear, distinct lines of accountability that are jointly set and covers key areas for joint working between the two employers. So joint recruitment, joint agreed inductions, joint job planning, joint appraisal, all of those things were fundamental in Follett Principles. Next slide. Thanks, Emma. But as time went by from 2001, that's 24 years ago, the policy context had changed. Momentum had grown in those 3 decades. And there are a range of documents that we've put on here for you. You will get these PowerPoints from today. You can see how things were changing about clinical academic research, about research enablers, around research delivery, around the face across the United Kingdom. And so the policy context changed very quickly, particularly in the last 5 to 10 years. So there started to be a call, really, that Follett needed updating because it was set for medical colleagues. And it really, although they had it applied to allied health professionals, that it didn't actually feel like it did apply. So that's where we started. Next slide. Alongside that, there were lots of papers coming out around a catalogue of enablers, barriers and aspirations, and we've named some of them here. Some of them were published, some of them were worked by CARIN members, pushing at the door. CARIN is excellent at its leverage, and some of these papers here showed that leverage about what worked, what could work, what didn't work, and what could work better. Next slide. So there were plenty of case examples for things not working, and we wanted to turn on those on its head to be solution focused. So things around lack of integration, effectively 2 part-time jobs, the playing off of employers. There was lots of reporting of that in terms of appraisals and disciplinary procedures. Lack of clarity over employer responsibilities, who carries out the occupational health, who carries the DBS, who pays for parking. All of those kind of issues were coming out to us as a group, as a network. There was lack of clarity between managing the salaries, managing the career progression, and who pays for what in terms of that. Many of our members and our reports, our work, and those articles that I cited before this slide talk about protracted regulations about salary and pension portability, and some, but not many, but it was there and it has been there in our debates in CARIN around the tax implications around the VAT. Next slide. So, it was time for an update. The next click, thanks. Now, this all started actually with UCEA, with the University College Education Association and NHS employers. They started to update their resources. If you look on their websites, both of them started to add to their resources. They added some slides, they added some updated resources, but we still hadn't actually updated Follett. And then they had conversations with the Council of Deans of Health, next slide, and CARIN. And so we raised that issue nationally, supported by Council of Deans of Health, as well as being part of that movement. Next point. And then alongside that, with all those documents coming out all at the same time, NHSC and IHR had a number of summits convened. And alongside with that, they had a number of strategies which were released. So the analysis and recommendations on how to accelerate growth in nursing, midwifery and allied health professionals really was sort of instrumental in saying, actually, it really is time for an update. And it was on the next group that really took it forward. Next bullet point. Thanks, Emma. And that is the Clinical Academic Training Forum. That is the national group where clinical academic training is discussed, and CARIN has a place at that committee. The chair of that committee asked if someone would volunteer to actually chair the update of Follett, and Professor Anne-Marie Keenan put her hand up. It went quiet for a bit because everyone knew this was going to be a massive job. So we really are, very grateful and thankful to Anne-Marie and the work she did at bringing that group together. Next slide. So what did we do to start with? So we started with discussing the history of Follett. We discussed if we needed an updated healthcare professional, clinical academic, because we didn't want it to say medical, nurses, midwives, allied health professionals. We wanted it to say health and care professionals in Follett. That was a massive change for Follett. We wanted to put some things around career trajectories and role attributes, but in the end, we decided that actually that was a separate piece of work. And we're very grateful that the Council of Deans of Health has actually led a task and finish group on that work. So that helped Follett working group to put that to one side and actually think about what were the Follett principles we wanted to include. And we wanted to include things around that joint working. So you will see it is inclusive, we hope, health and care professionals I've mentioned throughout, and it is about the United Kingdom. Next slide. The important elements for all of us is that it says all these things. It says joint recruitment and appointment, including agreed salary. It says jointly agreed inductions. It says around joint job planning. It says joint appraisal, and it says agreed procedures of performance. These are really important elements, actually, of Follett for us to include and think about always. Next slide. Unpicking Follett, when you actually open it, some people have said, oh, it doesn't seem much difference, but it actually is, because each sentence has been looked at and where appropriate has been made more updated and contemporary for us using it. So we've got things in there around integrated job descriptions. We've got things around agreed joint activities, joint decisions, accountability, and agreeing support. And we didn't want to make it too onerous as a document. The working group all felt it needed to be sharp, because that was one of the things that Follett originally in 2001. It was sharp to follow. So where we thought there was additional comments to be made, you will find that we have referenced that. And also UCEA and NHS employers have built some amazing resources for you to access should you need those. And they all connect. And I think that was a good way of doing it, to keep it sharp, that we can do that unpicking without making it too complex. Next slide. The one thing that I've put in yellow highlight here is we must, that's what we're recognizing and recommending. There must be a joint appraisal. Now, the word mandatory is not in Follett. Somebody asked me the other day, is it mandatory? No, it's not, and it never was. But we are recommending it within Follett, that this is the best practice to have a joint appraisal with two appraisers, one from the NHS or the employing health organisation and one from the higher education. To work with the appraiser in one single meeting, not two, that becomes complex with different aims, and then the appraiser has to put it all together, that there'll be one single meeting where everything is agreed and conducted jointly. Next slide. In terms of VAT, there is a statement on that. Compliance with Follett Principles enables an NHS trust and a HEI to demonstrate it's one job, not two separate part-time contracts. That's a different issue if you have that contracting, or a secondment arrangement is a different issue. And VAT is applicable on services supplied by clinical academics to NHS provider organisations, unless the clinical academics role is a joint appointment. We've also added some extra resources to help people navigate the VAT issues. That was one of the things that is quite complex. NHS employers have also put some packages for you to access around pension, about pension advice, as I say, VAT, memos of understanding. There's a number of resources they've updated as a result of the updated Follett Principles. Next slide. Well, the implications for CARIN is I want to say thank you to the members, because without the members of CARIN, without the Council of Deans of Health support, without CATAF taking it forward and Anne-Marie Keenan actually chairing, this would not have happened, and that shows about leverage. It is UK-wide. We need it wherever you work, if you're a clinical academic researchers, both in the NHS and the HEI, or healthcare organisations if you work in those, in some of the devolved countries. It might be that going forward, we need to think about that sign up and think about how this is being implemented. And it might be that some of us might need to look to the medical schools in terms of our own procedures and our own faculties, because it might be that we can work together within organisations to share best practices. We do need to spread the understanding of what good joint working looks like. We haven't put that in. It isn't there as a model. We have the principles and we can go forward from here. One of the things that has been suggested that CARIN takes forward is that we have a working group to lobby, where we would celebrate those that have a joint working, but also collate and monitor. So we will be asking members for case examples where it's working and sharing, because we want to celebrate that good practice and for others to learn from others. And to share sector-wide mechanisms and frameworks for clinical academic career progression, pension portability and pay scales. Those are things that are really important to CARIN and the future. Next slide. So just a thank you to you all and to Anne-Marie Keenan. And there at the last slide, we've put my emails if you need to ask anything extra about Follett that I haven't said. But also there's the resources. If you click on that, you get all the updated resources. But as I say, it's also within the UCA website and the NHS employers website. It's all repeated. So it's all there for you to access. Thank you very much. Thank you, Polly.
That's brilliant, Jane. Thank you ever so much for that really informative talk. We're now going to move over to Mary Wells. Mary is the Deputy Chair for Metrics and Input, and Mary's going to talk about the recent CARIN survey. Over to you, Mary.
Thank you. Can I just check, Polly, that you can see my screen in the right view?
Yes, thanks, Mary.
Lovely. Thanks very much for inviting me today, and I'm delighted to be able to share the results of the CARIN survey, which we undertook last year in 2024, but looking back over 2023. So as Polly said, I'm the CARIN Deputy Chair and lead for the Impact and Metrics Group, and in my day job, I'm a Deputy Director of Nursing for Research at Imperial College Healthcare NHS Trust and a Professor of Practice in Cancer Nursing at Imperial College London. And I want to acknowledge two key people who've really helped with the analysis of these results. Dan Lawrence, who's a research coordinator in Sheffield, and Ayako Noguchi, who is an associate professor in nursing from Tokyo, who spent her sabbatical with me in October and November last year. And I also want to thank all my colleagues on the Impact and Metrics group who have helped shape and interpret the data. So we've now conducted the CARIN survey 5 times, and we made a decision in 2021 to run it every 2 years. And the survey I'm reporting on today was undertaken in the spring of 2024 to summarise clinical academic activity in the previous calendar year, i.e. 2023. You can see on the slide here, for the last 3 surveys, we've used MS Forms to collect data on 3 key areas: research environment, clinical academic workforce, and outputs and impact. And we redesigned the survey in 2020 when I sort of took it over, and we've essentially kept most of the questions consistent since then, but we have added a few each year, and we've also made some adjustments, which I'll refer to as we go through. And you can see from the graph on the right-hand side of the slide that the number of responses has doubled since the redesign in 2020, which is great news. In 2024, we sent the survey to 53 NHS organisations and received 42 evaluable entries, a response rate of 79%, which is really not bad. And although they were mostly from England, as this map suggests, this was the first time we actually had at least one entry from each of the devolved nations. So that was very good news. As you can see from this slide, the vast majority of NHS organisations who responded were acute trusts, with very few from community mental health or integrated care organisations. And I think that's an important thing for us to consider, particularly as the NHR are increasing their emphasis on community and social care. We need to try and reach those trusts and ensure they have representation within CARIN. Not surprisingly, most of the organisations you can see here were very large, either over 1,500 staff or between 10 and 1,500, just probably reflecting the nature of the acute hospital trusts. So if we look then at the first section, which is about research environment, when we looked at strategic support for NMAP research, we found that 83% of organisations reported having an NMAP representative for clinical academics at the highest level research committee in their organisation. And that compares with 77% in 2020. So that's increasing, which is great. In terms of organisational statement of commitment or explicit executive support for clinical academic NMAPs, obviously that's a subjective question that research capability and capacity leads are answering, but we found in 2023 that 76% said yes to that question. That actually is also an improvement from 2020 when it was 59%. And when we asked people about whether they had a research strategy specifically for NMAPs or a strategy that had a particular focused NMAP component, 80% said yes, and that compares favourably with 2020 when it was just 64%. Looking at responsibility at board level for NMAP clinical academic research capacity and capability, not surprisingly, I think most organisations were represented by the chief nurse or the executive chief nurse, but a few medics, chief AHPs and research directors also in this capacity. We asked people to give us some comments on the leadership within their organisation, and we did have a lot of positive comments. The key themes that came across were things like partnerships with other HEIs and other trusts to support a joined-up approach, research articulated as a key priority within strategies, having NMAP professors within an organisation, NMAP representatives at a range of different high-level committees, funding for new clinical academic leadership positions, and high-level strategic support and commitment to clinical academic roles. And here's just a couple of examples of some of those comments. So looking at strategy, looking at a health board-wide research and development strategy, and having a very supportive narrative. There were some negative comments, although they were relatively few. You can see from here, from these things circled, that there were mainly issues around strategic support, representation and influence. And those that were made were quite powerful. So they illustrate that there are some fairly fundamental issues still exist in some organisations. We also looked at things like how HEIs and NHS organisations work together, and these questions were not mutually exclusive, but you can see here that the numbers are that between about 64% and 69% of organisations had some kind of joint working, and they were primarily in these areas of funding, supervision and training and research capacity development. Another environmental aspect that we looked at was whether organisations had mentoring schemes for NMAPs. And again, quite a good response here. 90% of organisations had some sort of mentoring scheme. That compares, is very similar to 86% in 2020. Research champion and or advocate or ambassador schemes are increasing across the board. You can see that about 75% actually this is either had one or were currently setting one up. So I'm going to move to the clinical academic workforce data, which I think you'll be very interested in. So one of the things we wanted to do was to look at what are organisations doing in terms of research capacity and capability leadership roles. And you can see that we broke this down by whole-time equivalent, and you can see quite a wide variation with 11 organisations here, just over a quarter. 11 organisations either saying they didn't have any or that this question wasn't applicable to them. There were also 11 who had whole-time equivalents of between 1.1 to 2, but there were a quarter who responded 0 or not applicable. And you can see that other organisations reported more than 4 whole-time equivalent roles, but the median overall was 1.3. So quite a wide variation. When we looked at the funding for those leadership roles, only 31 out of 42 organisations had said they had a leadership role, but in fact 38 gave some details of how their leadership roles were funded, so indicating that actually there was something going on, even though they answered no to the question around having a leadership role. And we think this is probably because 9 of those organisations indicated that the leadership roles were part of another substantive role. So people were doing something else, but had this as a kind of add-on to their role. 36 said their roles were funded at least in part by the NHS, 2 by the charity, and 23 by a combination of sources. And this was either NHS and something like the Biomedical Research Centre, or the charity, or possibly an HEI. This is the first time we've looked at this, but we decided it would be interesting to look at whether there was any sort of relationship between the whole-time equivalent capacity lead for research and the number of NMAP staff within the organisation. Obviously, we've got a very small sample here, but there was a weak positive correlation between the whole-time equivalent research capacity lead and the total number of NMAPs in the organisation. But that correlation is not statistically significant. We also asked people, do you have any other clinical academic NMAP roles? So this was other than those already declared as leadership roles. 25 out of 42 organisations said they had other clinical academic NMAPs, and within an organisation it was between 0.2 whole-time equivalents and 10 staff who were declared as other clinical academics. 10 of those organisations said that these posts were funded by the NHS, which was interesting, and the others didn't know or said they were jointly funded, for example, by an HEI and the NHS. The roles seem to be a mix of consultant and MAP roles and other clinical academic roles, including some joint appointments. But we had asked people not to include people who were on, staff who were on a clinical academic pathway. So, for example, people who were on NIHR doctoral fellowships. But we think from some of the notes that actually some people did record those as being clinical academics, which probably means that this data is a little bit messy. Now I'm getting onto some quite complicated slides here, so I apologise for the busyness of these slides, but I hopefully can pull out the main points. So when we looked at the number of NMAPs who had doctorates, if you first look at the response rate here, this illustrates the percentage of organisations who were able to provide a numerical answer for each profession. So in other words, although around 80% knew about their nurses and AHPs, only around half knew about some of the other professional groups. So you have to kind of caveat the results, knowing that actually these are not complete. If you then look at the blue box, this is the total number, adding up the total number across all organisations. And I've compared this with the response we had in 2020. So you can see here that in terms of nursing, 158 people with doctorates across the whole lot of organisations, compared with 86 in 2020. And you can see that trend pretty much down all the professional groups. But of course, we had double the number of organisations who completed the survey this time compared with 2020. So it's kind of not surprising that we've got an increase in numbers. But if you look at the median, so this is the median per organisation, it's really pretty small. So 4 for nursing, 4 for allied health professionals. And that's actually not very different from 2020. I think the interesting thing about this is discussion amongst our subgroup shows that most organisations don't record this information formally. Instead, people like me just kind of get to know who has a doctorate and may not know everybody who has a doctorate. And this time we asked respondents to include any type of doctorate, so PhDs and professional doctorates, for example. But we didn't specify that this had to be healthcare related. And we do know, certainly in my organisation, that we've got NMAPs who've got previous PhDs in engineering or some kind of other science or history, for example. And their research backgrounds are obviously still valuable, but might not be viewed in quite the same way as a health-related PhD. So if we look at the doctorally qualified staff who are actively involved in research, this is also interesting. So you can see on the left here, this is the same medians that you've just seen on the previous slide. If you look at the number of people who the capacity lead thought were actually research active, you can see the medians go down quite considerably. And by the way, I should have said that nurses and midwives jointly are greyed out, mainly because we left that in case people only had nursing and midwifery together rather than nurses and midwives separately. But you can see across the board that most of the data on the nurses and midwives is pretty patchy and the response rate is very small. So I think I would really not look at that, but I've just included it for completeness. So this was a new question this year, so we can't compare it to previous years, but it does seem to show that we've got people with doctorates, but they're not all research active, which I don't think will surprise any of you. Of course, how we support our doctorally qualified staff within the NHS is an important factor in whether they can actually be research active. And so we asked people for some free text comments on this. And we found that a third of organisations left this column blank or said there was no specific support for this group, which kind of, makes you realise, well, that might be one of the reasons why our doctorally qualified staff are not research active in the organisation. Interestingly, funded time and other support were the things that mainly came out of this question. 5 organisations had schemes specifically to provide research time for postdocs. So that's encouraging, but it's obviously a small number. Some had dedicated time in their job plans. And really, I suppose the overall impression was that bespoke arrangements were being made for individuals rather than there being a kind of pattern or a trend overall. And then there were other types of external of support, so small grants, opportunities for fellowships and being local PI, support from R&D, training opportunities, dissemination, support groups, access to one-to-one mentoring and encouragement, for example. Then we looked at the numbers of NMAPs who were enrolled in doctoral programmes. And again, you can see the total number seems to have increased quite significantly, but albeit we've got more organisations responding. You can see that the response rate, again, for this is a bit variable. But the medians by organisation were exactly the same as in 2020, sorry. But, we have to remember that there's a lot of variation in how much organisations actually know about their doctoral candidates. and not surprisingly, where it was possible for organisations to comment on clinical psychologists, numbers were quite high because a doctorate is a standard part of training for this professional group. So then we looked at whether there were local or regional schemes open to staff. We know that the national schemes like the NIHR are only open to England, but we wanted to know what was available locally or regionally across the organisations. And we're seeing a much better picture here. This red dotted line is really just showing you half our sample here, but you can see quite a lot of organisations with internship and doctoral schemes and fewer for postdoc, pre-doc and MRes. And this is just a comparison of the numbers in 2020, but remember, fewer respondents that time. Looking at the total number of postdoc fellowships across all organisations, this just gives you the nursing, midwifery and AHP because the others really are very incomplete. But we've got bigger numbers across the board in 2023 than in 2020. But remember, again, we've got more people responding. But that seems like a promising picture. This time, and apologies for this slide looking rather confusing, but this time we decided to ask organisations how many fellowships they held for each staff group which covered their salary and how many did not, because we all know that there are challenges in if there's a fellowship that doesn't cover salary, it's actually very difficult to backfill. Even if there's a fellowship that does cover salary, we know it's very difficult to backfill, but not having salary at all is quite a challenge. So if you just look at the medians, they're not very exciting. 0 across the board. You can see maximum numbers per organisation are relatively small, but you can see that there's quite a lot that are not covered, where the salary is not covered. Then we looked at doctoral fellowships across all organisations. So these slides are going to sort of mimic each other for the next few. And we found that there were 122 for nursing, 16 for midwifery, and 141 for allied health professions being recorded in 2023, compared with 59 in nursing, 41 of which were actually self-funded in nursing in 2020. So a lot more doctoral fellowships happening, but again, more people answering. We looked at the same thing in relation to whether salary was covered or not covered, and you can see a lot more. I mean, the medians are slightly better. You can see the maximum number of funded fellowships per organisation being quite healthy for some organisations in terms of funded fellowships, but still quite a number where the salary is not covered. Then we looked at pre-doctoral fellowships across all organisations, and again you can see a similar trend. So we've got higher numbers in 2023 across the three sort of core groups where we have better data. So much better than in 2020, albeit more organisations responding to the 2023 survey. And again, similar picture, the medians aren't very impressive, but generally it seems that there are more funded salaried pre-doctoral fellowships now than non-salaried. And then finally, the research internships. Median is still pretty low, but the total number of internships seems to have got more healthy since 2020. Okay, I'm just going to move on to the last section of the survey, which is outputs and impact. So for the outputs and impact section, we asked about whether people held a conference and celebration event, and we also asked them if they collected data routinely on number of conference presentations. And you can see that 33 out of 42 said they did hold a conference celebration event, and 32 out of 42 collected routine data. And that was an increase for both since 2020. We also asked, do you collect publication data for your organisation, for your NMAPs? And half said yes, half said no. That was about the same as it has been in previous years. And we asked people about, did they keep data on grants and fellowships? And this is probably a little bit more surprising, that a minority did keep that data, did have that data, again, similar to previous years. And 45% were actually unable to provide this information. So this is clearly a big challenge for organisations, and it ought to perhaps be something that's a bit simpler. When we asked people about impact and activity and whether they collected data on impact, 55% said they did. 55% said they either did or it was in development, and 38% said they produced an organisational annual report. Now, I'm going to have to skip through some of the detailed slides because of the timing, but obviously you can see these later and this will be recorded. But in terms of what people collected for impact data, it was a whole range of different things, and they collected them through an impact assessment tool, electronic platform, spreadsheets, Qualtrics, or ad hoc. So a range of different things going on, and that's something we would really like to be able to look at and improve. For the first time this year, we asked about challenges in relation to equality, diversity and inclusion, because we felt this was really important. And the challenges that really came up in this free text response were a not surprising lack of diversity in the clinical academic community, certain groups being less likely to access fellowship and training opportunities, and particularly greater support needed to encourage both the internationally educated staff and those from minority ethnic groups. What was great to see, and I'm sorry there's a lot on this slide, were that there were a lot of EDI initiatives in place across the organisations that were doing something about it. But perhaps worryingly, 10 organisations said they weren't really addressing EDI issues or didn't know what was happening. But you can see here EDI strategies, working specifically with different communities, ring-fenced and targeted fellowship opportunities, stakeholder groups, collection of EDI data and that kind of thing. Getting to the last few slides now, but we also asked people what were the greatest achievements they felt they had in NMAP clinical academic growth or activity for their organisation this year. And you can see just the numbers who said something about each of these kind of key areas. We've themed them into these key areas. So either new appointments and roles, funding and grants, strategies and frameworks, programs and initiatives, and achievements and events. And I'm just going to give you a couple of examples of those. So 2 new NMAP professors in the partner HEI, staff successful in large grants, more structured clinical academic career pathway, development of centres or infrastructures, and success rates in NIHR applications. So those were the kinds of things. The greatest challenges will not surprise you. They remain quite considerable, and there was a lot to say, which is why this slide has got such a lot in it. But we've grouped them into operational and financial pressures, lack of infrastructure or support, culture, context, funding, capacity. And you can see there's some nuances within that. I'll just let you have a look at that for a minute. I don't think there's anything very new there. But many of these challenges are connected and, of course, have knock-on effects. So I'm going to thank IACO for this slide, but, you know, you've got operational and financial pressures in an organisation, clinical manager support's then challenging to secure, and that of course hinders the creation of new roles and staff release for opportunities. So these things are all very interconnected, and we therefore need to address the sort of the whole as well as the the sum of the parts as well as each of the individual parts. So in conclusion, I suppose the key things that I think we need to consider are that although most CARIN members are now responding to the survey, which is great, we do need to engage more members, particularly those in the community organisations. We've got lots of challenges for many organisations in both collecting and or retrieving accurate data, and that surely is something we ought to be able to do something about. So we don't know who our doctorally qualified staff are. Could we not just get that added to the health roster systems in our organisations or something so that we could gather that at least? Number of fellowships and grants, it ought to be possible for our R&D departments to tell us what they are or to have some sort of link with the NIHR, and I don't know, but that's something we ought to be able to do something about. Number of publications. We know that some organisations have fantastic support from, in fact, many organisations from their HEI library colleagues, and that there may be ways of collecting that data more reliably. And data on income into the organisation is something I've kind of referred to already, but ought to be possible to collect. And just to note that all of this seems to be better for nurses and AHPs and less so for midwives and other professional groups. So we just need to think about why that is as well. I do think we need to think about the fact that only about 50% of our doctorally qualified NMAPs are research active. I mean, some of them may have chosen not to be, but how many are we effectively choosing for them not to be because of the lack of support we provide and the roles that don't exist for clinical academics across the NHS? EDI clearly needs some attention, and key challenges really persist. So I want to end with something a bit more positive, because I do think this shows that we really have grown and we are continuing to grow, and the influence of CARIN is really very far-reaching. And I just want to thank my colleagues again before I finish. Thank you very much.
Thank you ever so much, Mary, for that fabulous talk. So much data, really, really comprehensive. We will open it up now for questions, and I can see that there's been one question that has come through regarding the Follett. So let's give Mary a break for a minute or two, because she kept very well to time, and I'm going to move over to you, Jane.
Thank you.
The question is, how can the use of Follett Principles in joint appointments ensure equitable pension arrangements for nursing, midwifery and AHP clinical academics?
Oh, it's a really good question. And we discuss this a lot, you can imagine, in the working group. I think CARIN's role in this is that we keep pushing that. But I think the answer in the working group was that NHS employers felt that pension was something that was discussed on a personal level by that individual in the joint appraisal and consultation process, because the options were so varied. So what NHS employers have done, and it's not to try to get out of it, but they put in lots of resources within Follett. So when you go on to NHS employers, there's the resources for the pensions, Polly. But it isn't really specifically mentioned because NHS employers felt it was an individual's decision and discussion. But I do think in CARIN we can take this forward. So if members want us to, I think we ought to have that debate, but it's not really there, evidently. VAT is, which I'm delighted at. But yeah, the resources was the answer for that one at this point. I think when you look at Follett, as I said in my presentation, you think, oh, has it changed much? But it's the individual words and the push that's now there. We've now got a line in the sand from where we can go, and it's all health and care professionals, which is fabulous to celebrate.
And all 4 nations, Jane?
Yeah, and 4 nations, absolutely. 4 nations and all healthcare providers and HEIs. Thank you.
Wonderful, thank you. I can see we've had a second question come in. So this question, I don't know which one of you wants to take it, but how can we ensure equity of opportunity for clinical academic roles across professions? Mary, should we go to you?
Shall I start? I mean, I think that's a huge question with probably a very, very large answer. I mean, I think that I feel like, having sort of seen this survey kind of develop over the last few years, that we have improved the leadership situation for particularly nursing and AHPs. I would say less so for the other professional groups. I mean, you'd think that midwifery would kind of come under nursing, but I think it kind of gets a bit separated, and I think possibly isn't as well represented. And I think for healthcare scientists, pharmacy staff, and clinical psychologists, it's more difficult. There are fewer roles that cover those groups within organisations. So I think leadership is one factor. I mean, I think, there are so many reasons why, for example, the AHPs seem to have had a longer trajectory in being successful in fellowships. And I think it's going to take a while for the others of us to catch up. And I think there's it's an interesting question as to why that is. So I think leadership is important. I think that dissemination and reach is really important. And I think it's hard within large organisations where there are very large groups of professions, particularly nurses. I'm a nurse, so I'm probably biased to sort of make that happen. So, I mean, those are just some things to throw out, but they're not answers, really. I don't know if Jane would add anything else.
No, I agree with you, Mary. I think leadership is individual, local. It becomes regional. It becomes national, and in all of those layers, in CARIN we have championed inequity, because leadership also relates to opportunities for funding or fellowships, and we know that isn't a level playing field. In the work of CARIN, so people know, we have really developed since in 2024 the two groups that Polly mentioned at the beginning, which is an EDI group and also the devolved countries, and we are collating that work and championing that work. There's been some fabulous work. I know Juliet's online, I'm sure, but Juliet MacArthur and her group have published this work for Scotland. We are really championing those different countries and the opportunities as a result. So we, as CARIN, we knock on those doors, don't we, Mary? Because that gives us that privileged position to do that and deliver leverage. So if you aren't a member and want to become a member, please contact myself or Emma Sean Bell after today. But yeah, I agree with Mary on the comments.
Thank you, both of you. Questions are still coming in. So a question we predicted might come over to you, Mary. So will SORT assist in further data collection and developing and building clinical academic pathways and infrastructure?
Yeah, it's a very good question. I think some people have sort of wondered what's the difference between SORT and CARIN. I think they're actually very different, and I know Parveen would agree with me, who designed with colleagues the SORT tool. So I think SORT might help in further data collection and developing clinical academic pathways and infrastructure, in that I think SORT will help us to look within our organisations on a more granular level what we can do locally to improve research culture, and therefore you would expect that to then have a knock-on effect on the benchmarking survey that CARIN does. But I mean, they're kind of indirectly linked, I would say, rather than directly linked. I mean, I think we've also got to do something about our ability within an organisation to collect data that we can then produce for CARIN. Having said that, I think a lot of organisations have said that the CARIN survey has helped them to be better at data collection, because they've kind of been forced to think about how they're going to find the data to fill in the CARIN survey. So I think there's been a sort of chicken and egg situation with that, which has actually been quite positive. And I think SORT can only help in kind of attacking it from a sort of slightly different direction.
Brilliant. Thank you, Mary. A couple more comments and questions coming in. So how can CARIN facilitate covering salaries, etc., to progress research careers in organisations across the UK? Do you want to take that one, Jane?
I was going to say, in part it can't, can it? But it can in another way, in the leverage, because it's about it's about looking at the banding and thinking about those roles. I'm involved in a project that started in the West Midlands, but has now come to CARIN members and will be coming out this year, and that's looking at the actual roles expected in the job descriptions and person specifications, which relates to salary. And the disparity is there in the actual criteria of job descriptions. And I've, brought the data in. We've got 35 different job descriptions and person specifications from across the country, UK wide. And I've been quite surprised with the different elements of what's being expected to band 5 to a band 9, for example. So I think in there, we need to get the role descriptors clear. And we've tried this work before, and we've tried it a couple of times, but hopefully if we can try and push that from CARIN about those role descriptors, then we can align that in some way to salary. And we've had those discussions in the devolved countries as well in our group, in our package work.
Brilliant.
No fast answer, Polly, but that's our building blocks are there. So yeah,
still work to be done, but heading in the right direction. This will probably be our last question. And so someone says online, I think there's work to be done to address the approaches to assessing workforce requirements for workforce planning, as they all focus on direct and indirect care and do not appear to include research. Do our panel agree?
Yeah, definitely agree, Debbie. I mean, we've done a bit of work on trying to, we've designed a new language, as it's called, for electronic job planning that includes research as one of the 4 pillars for our consultant roles. Not just in nursing, but across the board, which try and emphasise the fact that there are a number of aspects of indirect and direct care potentially that are research orientated. But it's been a real struggle to get that kind of implemented. So I think, and I mean, that's just for one small group of staff, very small group of staff. I think absolutely, we've got to now start influencing our workforce planning tools in whatever way we can, even through things like getting doctoral qualifications added to RE rosters and that kind of thing. So yeah, it's a huge piece of work. And if anyone's got any ideas, I think we should pull them and try and influence on a national scale.
And I agree with Mary, Polly. And someone else has asked about sending cases to Follett. Please do send them to Emma and or myself, and we will start that work. Yeah.
Brilliant. Well, it's exactly spot on 3 o'clock. So it just leaves me to thank again our speakers, both Mary Wells and Jane Code. Thank you ever so much for great talks today. I'd also like to thank the Council of Deans for hosting the webinar and thanking the audience for their participation and their questions. Just 2 little points. So one, CARIN is having a face-to-face meeting on Thursday, March the 20th in London. And that's for CARIN members who represent their organisations, and they hopefully who knows who they know who they are. And there's 2 members of those per organisation, but you can bring someone else in your place or bring an observer. But please let Jane and Emma know that in advance. And as Jane said earlier on, if anybody wants to be added to the CARIN membership, then please just drop Emma or Jane an email and let them know. So thank you ever so much.